Thanks a lot, Mr. Chairman, and thanks for this invitation. This idea originally came from this sort of editorial point of view that we wrote for ICM, but I tried to adapt the 10 false beliefs to this session, which is mainly technical. So I modified slightly that paper that was published last year in Intensive Care Medicine. And these are the points, since there are 10, and I couldn't shorten my talk, I will quickly go through them. So first false belief could be the fact that effluent flow equals RRT dose. Well, this is not completely false. It is only true if a small solute sieving coefficient equals 1, such as for urea, but probably this is the one or the only solute with this condition, or full saturation of dialysate occurs during dialysis, and the effluent flow, in this case, the effluent flow equals treatment dose. But this should be done in post-dilution, continuous veno-venous hemofiltration, or low-flow continuous veno-venous hemodialysis. We tried many years ago to verify this stuff, and what we found was that generally, if you compare measured and estimated clearance by doing the dosing of the urea and creatinine, you generally have a overestimation of the clearance given by the effluent flow rate. Other reasons for this overestimation are given by the fact that we well know that every time we prescribe a treatment in milliliters per kilogram per hour, generally the delivered treatment is lower than that. Then we don't know what really happens during over time in our membrane. We have to take into account pre-dilution, clogging, clotting, protein fouling. So we can conclude this first belief that generally effluent flow overestimate RRT dose. Another, let's say, almost false belief might be that TMP should trigger filter change. There are not any data published over there. I found this study in pediatric nephrology where they found that actually the filters with a TMP value that was increasing rapidly over time tended to have a shorter life than filters with a TMP that tended to remain stable. But still, we currently don't have any absolute TMP transmembrane pressure level to decide when to change the filter. We don't know how steep should be the trend in order to inform us about the change. Then again, I have to tell you that the sieving coefficient of the solutes tends to decrease over time, so we should not rely only upon transmembrane pressure and the fact that the machine allows us to continue the treatment. We have to know that the solute clearance of our treatment is decreasing, so we have to take into account this fact. And again, in that study, we realized that after 18 hours, you see the purple squares were mostly those of the older treatments and tended to be overestimated in terms of clearance. So probably not only transmembrane pressure should trigger filter change. Blood flow rates cause hypotension. This is another commonly stating a fact that I hear every day in my routine practice. But the thing is that per se, blood flow rate cannot be responsible for hemodynamic instability because blood runs into a closed circuit. So all the amount of blood that I'm withdrawing from the patient at steady state, I mean not when the treatment is starting, but at steady state, I'm withdrawing the same amount of blood that I'm returning to the patient. So this is not the reason for hemodynamic instability. There is no difference if the patient is running 100, 150, or 200 milliliters per minute in terms of hemodynamics. Other reasons are responsible for hypotension. For example, at the start, if I'm not reinfusing the withdrawn blood, if I'm ultrafiltrating the patient at a rate that is higher than intravascular refilling, if I'm diluting vasoactive drugs, if I'm causing to patient disequilibrium syndrome. Again, these are commonly routine statements. There is nothing published there about this. The group from Australia with Ian Baldwin tried to verify what could happen in terms of hemodynamics if I start the treatment slower than what routinely done. And what they ended up with was that if you actually are able to start slower, it takes more time to fill the circuit with blood. But then you realize that the hemodynamics, when you run a treatment, especially in the first hours of the treatment, are completely unpredictable and does not really depend on the way you start the circuit. And this is interesting because recently a quality meta-analysis tried to verify something about hemodynamic instability during CRRT, and what they found was that the problem is indeed a problem. It occurs frequently, probably in half of cases of treatments, and this is nevertheless based on nothing. So very few studies tried to verify how could we address the hemodynamic instability. And you can see here only 5 RCTs. Most of them were related to intermittent treatments. So at the end, we can conclude that there is no responsibility for blood flow rate to cause hypotension, but still this is an issue, and still we have to deal with it, especially in the literature. Okay, KDIGO guidelines tell us that jugular vein is the best access for RRT. We well know this. Generally, we prefer it to femoral and to left jugular vein and to subclavian vein. We tend to avoid subclavian vein due to multiple reasons, bleeding and stenosis. Left jugular vein might be not a good idea due to this shape that occurs to the catheter when you put it into the innominate vein. But we have some interesting information from the literature in terms of performance of dysfunction and deep vein thrombosis. The femoral veins are very good veins. So there is no reason actually to prefer right internal jugular to femoral veins, especially because frequently in our patients the right internal jugular is the first choice for drugs delivery, so probably you will find it already occupied. So in conclusion, you see that we could state that right internal jugular vein and femoral veins probably are the best accesses for RRT. High-dose diuretics and volume are the right tools to stop CRRT in the anuric patient. Again, this comes from many discussions I have during CRRT treatment. And many people say, okay, the patient is not making urines because their CRRT is ongoing. Let's try just to stop it. But we know from the KDIGO, even if this looks obvious, it is not. You have to discontinue RRT when it is not longer required. So you're not really authorized to stop RRT when the patient is anuric, and probably diuretics does not help. This is being showed very clearly by the best kidney authors in this wonderful observational studies worldwide large, and they found that when the patient achieve at least 400 to 500 milliliters per day of urine spontaneously, then you'll have a good chance of interrupting the treatment. This is counterbalanced by the use of diuretics that confound. So the best thing is to wait for spontaneous diuresis, and then you can probably try to challenge the patient with RRT winning. Another interesting study evaluated the quality of these urines, And they ended up by saying that if you measure urinary urea at day 2 after the achievement of spontaneous diuresis, if you have this level of 8, then you might have good chances of winning your patient. So the suggestions here are wait for spontaneous diuresis and try to measure urea and quality of the urines. My message here is that there is no evidence that forcing CRT winning in patients without signs of renal recovery may have any clinical effect. Extracorporeal therapy is the cure of sepsis. I will go quick on this because we well know today that we cannot attempt to take care of a septic patient just with the CRT. We can use CRT as an adjunct therapy. We must have a target for our treatments. The target could be fluid balance control, electrolyte control, acidosis control. For example, the control of mediators, if I'm not dosing them, is not acceptable anymore because we don't have evidence that this occurs. So you can use extracorporeal therapy as an adjunct therapy for sepsis, not as a cure. Connection of CRT to ECMO is harmful. This is the object of my last talk half an hour ago. We don't really know if it is feasible to connect two devices that were conceived to work independently. But then we know that fluid overload in ECMO patient, for example, is an issue, and it is independently associated with mortality, independently of severity of disease. So when I start an ECMO treatment, if I see that the patient is getting oliguric, it might be a good idea to start proactively and possibly without adding another vascular access in a patient with anticoagulation. So even if we know that mortality probably is increased in patients who are undergoing ECMO and CRT, we also know that if we stratify this patient for the severity of the illness, we know that the most severe are the ones with the less impact by CRT. And probably this is a beneficial impact of CRT because these patients might be the most fluid overloaded. We know that there are some schemes on how to connect the filter to the ECMO. And again, I suggest not to connect just a filter, but a full CRT machine. You can do it by connecting inflow line after the pump and reinfusing before the ECMO pump, or just in the same limb. Again, this group tried to in vitro verify if there is a good position, a best one, in terms of thermal energy expenditure. This position between the pump and oxygenators appear to be the best one. What we should not do ever is to connect the filter and the machine in line with ECMO blood flow and jumping the pump, because in this case the highest risk of gaseous microemboli exists. Anticoagulation is always needed during RRT. I don't know your position on this, but I do not agree. Probably this was much more an issue before of the citrate era, but still anticoagulation causes hemorrhage. And today we cannot afford to cause a so significant side effect to a patient just because we want to prolong the filter life. Yesterday, we heard very clearly that one of the best anticoagulants is the perfect vascular access, and when your vascular access works, you need very few levels of heparin and other anticoagulants. Then you have to deal with high-risk patients, and in these cases, every time you can achieve a treatment lifespan of 20 to 24 hours, then you might think that you achieved the benchmark, and so you should not push for longer treatments. Then you have some cases in which you can reduce anticoagulation. For example, patients who are receiving already other anticoagulants, such as warfarin, or, for example, patient anticoagulated with heparin in ECMO. In these cases, I don't think you need an additional anticoagulation in these patients. What do KDIGO guidelines consider high bleeding risk? A recent surgery, a recent trauma, a recent stroke with intracranial hypertension, and the presence of an epidural catheter. In all of these cases, please just consider not to use anticoagulation in your patients. Again, from Australia, this milestone study back in 2000 clearly showed that not only you don't need anticoagulation in high-risk bleeding patients, but you will end up with probably longer treatment in these patients because you will have less side effects. Pre-dilution hemofiltration reduces CRRT efficiency with respect to post-dilution. This is quite technical, but this is one of my best. We do know that pre-dilution reduces instantaneous clearance, but instantaneous clearance overestimates 24-hour CRRT intensity, which is a function of time, so we have to consider downtime. Filter efficiency falls over time. I showed you in the first belief. Then pre-dilution can theoretically optimize filter patency. So if we have, unless we have some reduction in instantaneous clearance, we have an optimization of downtime, then at the end we might end up with a better efficient treatment. This is essentially due to this fact. This is an old but still valid Claudio's slide, where you realize that when you dilute the blood entering the hollow fiber, you end up with less filter clogging and fiber clogging and less deposition of proteins in this area, and this ultimately causes an optimization of rheology inside the filter. Not only this, another interesting fact is the filtration fraction. If you have the same settings in a machine and you try to measure or calculate filtration fraction in post-dilution and in pre-dilution, you end up by having a lower filtration fraction in this patient. This is good for the filter. But not only this, probably when you're using pre-dilution and you have low blood flow rates, you might be increasing a little bit the threshold between the blood and the effluent flow rate, and you might probably increase a little bit the filtration fraction. So in this standpoint, pre-dilution might be a good idea because it helps you to optimize the filter settings. The last one, that was probably the weakest false belief. I don't know your opinion about this. I don't think actually that all modalities are made equal, but again, this statement is probably nothing more than a personal opinion. This meta-analysis that is not so recent tried to verify all the studies that try to compare, for example, hemofiltration versus hemodialysis. Some of them compared hemofiltration versus hemodiafiltration, and you see only 3 randomized one. The last one is the Omaki trial that was actually a feasibility trial, that there was no follow-up to these studies. This is worrying. But you see the diamonds, there is no actual effect on mortality depending on the treatment that you're selecting. What is a fact is that the clearance of middleweight molecules and larger molecules is optimized during hemofiltration. So if this is indeed your attempt and your indication for the treatment, probably you should move towards the filtration part. Another important thing of this study is that they try to evaluate what happens in different countries, and you can see how different is the selection of prescription. And probably the message here is that we don't really know why we select one modality or the other. And the editorial of this paper was very inspiring, because it says that probably the selection is due to personal convincement, expertise in every center, but probably we should be more selective and try to distinguish between a patient that deserves larger molecule removal and patient who do not. So this is my conclusion. Effluent flow overestimates actual CRRT dose. Probably transmembrane should not be the only way to decide when to change the filter. Blood flow rates per se do not cause hypotension. Right jugular and femoral accesses are good. Diuresis volume and urinary creatinine probably might be a good idea to win RRT and not other exotic attempts. Extracorporeal therapy is indicated to support the sective patient, not to treat him. Connection of CRRT to ECMO is feasible and in pediatric setting is mandatory. We are not allowed to put another access to children when we have to start CRRT. Anticoagulation is not always needed during RRT and probably is less needed or is not needed in many, many cases. Pre-dilution hemofiltration is good for the filter and optimize performance. CRRT modalities might be selected according to patients' clinical needs and not on personal vague opinion. And with that, I thank you for your attention.